personal note, we had the pleasure to meet with Bethany about 2 months ago, our team, and it really became apparent that the National Center for Medical Legal Partnership had chosen an incredibly dynamic, thoughtful, and passionate leader for, as she calls it, MLP 3.0. We are really excited to have her here. She's an incredibly thoughtful person and has terrific ideas to lead medical legal partnership into the next, well, I would call it the next phase of medical legal partnerships. And I did want to include one thing from her bio, and you certainly should feel free to look that up on the National Center for Medical Legal Partnership webpage. But here are Bethany's top quotes that she put on the webpage. Make it happen, challenge accepted, fix your face, I've got a song for this, and you've got this. And if that doesn't sum up Bethany Hamilton, I don't know what does. So again, it is my pleasure to welcome Bethany Hamilton to our Connecticut convening. Bethany?
Thank you so much, Jay. I appreciate that. Apparently, Liam also had a song for this morning. I don't know the title of the song, but Liam definitely went back to throwback by you too. So I'm not alone. I'm not alone. Good morning, everyone. Good morning. Good morning. My condolences as well to your dear colleague that you lost, as well as his family and friends outside of the MLP world. So my condolences as well. I'm going to do a screen share here, but I do want to note that I greatly appreciate following Liam, James, and Ada this morning, because they really, I think, set the stage for the tone that I'm trying to use and the message that I'm trying to convey this morning. What I'm going to talk a little bit about is how medical legal partnerships are poised to really address that post-COVID-19 world that we've been really hoping for, really since the declaration of the public health emergency. We all thought it was going to be 2 weeks. Then by the summer, we'd be done with this. Then by the fall, and it just kept going. Let me first say this. For medical legal partnerships, especially in the state of Connecticut, you all have been way ahead of the curve prior to COVID, certainly during COVID, and you will certainly be so afterwards. And I'll explain a little bit more as to why. Before I do that, though, let me take a little bit of a step back and say, how are we really doing? Really, though, how are we doing? We have long accepted as our ideal, right? On the facade, at least, of the United States Supreme Court, that equal justice under law applies to all of us. That's what we've accepted, at least as our ideal in this country. Yet we still have this justice gap, and 71% of low-income households around the country continue to experience at least one civil legal problem in the year that LSC did their justice gap analysis. 86% of those civil legal problems in that year received inadequate or no legal assistance or help at all. That amounts to almost 1 million to 1.2 million people not receiving any sort of legal help for problems that they had. What else have we long understood? We've long understood what the World Health Organization called social determinants of health, right? Those are the conditions that we're born in, the neighborhoods we grow up in, where we live, where we work, and our age. And it can go on and on. Those are the socioeconomic conditions that we talk about. But again, yet again, we still have these health gaps and these inequities, and we saw it play out. We saw it play out even though we put in place the Affordable Care Act and people gained insurance. By the time we reached 2019 and 2020, the act that caused so many folks to gain insurance and healthcare access was weakened, and we saw that we had then lost coverage for millions of people. And then similarly, when COVID came around and people lost their jobs, right? Then we also saw that individuals who were working, as well as children, because when children have insurance, or when parents have insurance, children are more likely to have insurance. They also lost coverage. But we heard, I think Liam, James, and Ada also all referred to those other inequities that exist because of race and wealth and economics, right? And we certainly saw disproportionate impacts of COVID-19 based on race and ethnic minority, as well as wealth. But we really saw that stark contrast in the way COVID-19 impacted populations across race and ethnic groups. All right, So what else do we know? We know the extent of the social needs. You all have probably seen, if you've tuned into the national centers or other MLP presentations, we are up to about 90% of a person's health being determined by social factors. And you all have probably seen our iHealth chart and recognize those graphics. Income and insurance, housing and energy, the employment, legal status, personal and family stability. Those are all of the sorts of social needs that we've often said lead to or can be addressed through a legal intervention. And in fact, what LSC found was that civil legal problems related to health and then consumer and finance issues affect more households than any other type of issue. So where are we? Fortunately, we do have that evidence-based solution, and you all are here and gathered because in preaching to the choir, you know what it is. It's the medical legal partnership. Some of you may be newer to this space. Some of you are, in fact, the originals who created this. I'm going to go all the way back to 1967 and give credit to another individual that we just lost, a giant in this social medicine, social justice field, Dr. Jack Geiger. In 1967, he actually hired a lawyer at Delta Health Center down in Mount Bayou, Mississippi, to really help to address patients' food insecurity and housing problems. That wasn't a formalized medical legal partnership, but we do see the role that a lawyer played as an intervention to help address those social, economic, and environmental factors that contributed to health disparities. Then you fast forward to the 80s, where healthcare institutions were working closely with civil legal aid agencies to really address the HIV/AIDS epidemic. And then you come into the 1990s, where folks in Boston, Massachusetts, as well as in Connecticut really said, hey, let's formalize this thing and make it work. And that's where you saw really pediatricians step up to the plate and really band and join forces with the legal community to form what we now call medical legal partnerships. All right, so beyond the definition, the National Center has certainly managed to segment with your help as the field. You all have been doing this a long time, you're very advanced, but we've been able to really cull information and data from the field to say, basically, we have some core medical legal partnership activities, and those include everything from direct legal assistance to training, clinical level changes, and then policy level changes. That's a lot of the space that we're in right now. I believe James was the one who mentioned that, when we're really moving forward, let's start to think about those public-private investments to really scale the model and its impact. What I'm going to propose is help you, or what I'm going to hopefully help you to do is help you make the case as to why medical legal partnerships are the intervention to invest into. First, why are they unique? We all know, right, this chart, again, it's iHelp, where we categorize the different types of social needs, but just basically, and you'll see that I highlighted, some of the ways that lawyers can really help. You know this very well already. I used to do it when I was in civil legal services, really helping people apply for, because that's the first barrier, and then if need be, appeal any denials of public benefits. Those are the bread and butter that sustain civil legal services, because that's what people need. And as we've seen in COVID, housing and utility shutoffs, right? Those are the sorts of things that we continue to do and address through medical legal partnerships. You all know this very well. It's really just to help you sort of make the case as to why medical legal partnerships are a unique intervention bringing together these two disciplines. And we know that these two disciplines, when they come together, legal services and healthcare organizations, that marries well into a really good and strong, solid response to social determinants of health. I mentioned Dr. Geiger. He wrote a prescription for food in the 1960s. You can see, fast forward now, we're still dealing with food deserts and individuals who don't have access to healthy foods, whether it's because of a health condition or just because of an income insufficiency problem. So you're in a health desert, a family needs fresh foods or produce. What is the legal need? A legal intervention, whether it's a lawyer or paralegal, would step in and assist with the benefits appeals, such as for SNAP or some other sort of income assistance. Furthermore, we know that medical legal partnerships continue to be unique because they are, unlike other partnerships, they really are well suited for tackling both the individual needs and then the underlying policies. So that goes to that pizza pie chart that I showed a little bit earlier about the core medical legal partnership activities. So that's what we think makes it unique. We also believe, right, in making the case for why this works and why you should really be pushing for sustainable funding, the buy-in from your state legislators or at the federal level or with healthcare partners, is because the MLP approach is flexible. And we know already, based on all of the years of experience out there, exactly how to build it and for each community. So right now we're accounting for about 450, if not more, because we are going to do another survey through the National Center so that everyone knows who everyone is, because our power is in our numbers, right? So we know there are about 450, and we don't think it's just in 49 locations or states plus the district. We think there are probably some forums in Puerto Rico, right? Let's go out further and see where folks are doing this and doing it well. We also know, based on what we've seen in the field, that there are about 3 basic different approaches to addressing social needs. So for newer MLP folks, one of the questions we often hear, especially from the healthcare partners, pertains to, well, do I have to address everything? I recently heard from a hospital partner who is in a legal desert. And it's like, well, there are all of these things. We know that there's this very serious problem for individuals who are in the hospital, but they also have all of these other problems that they want to address. The model, the approach is flexible. There's no one size fits all. That's what makes medical legal partnership a strong and unique model. We also know there are different types of legal services. You all know this. Many of you probably carried this out. Some of you probably adjusted to doing curbside consults during COVID, while others continue to do the direct in-depth legal counsel and advice to patient populations. But even with all that variation and flexibility, we know, sorry about that, that's my finger moving really fast, that there's some basic components to medical legal partnership, right? You may have a lawyer who's in residence, you may contract it out. You know that you'll have an MOU, or you're choosing to address very specific target populations. We know this now, that despite the variation, there are some basic components. What else do we know? We finally know how to staff it, or we have a better sense of how to really staff a medical legal partnership. Earlier in my presentation, I noted that it's not just your lawyers, there are your paralegals, there are your law students, your law clerks, community health workers were mentioned earlier. So there are various types of ways that you can staff it, but we have a much better sense now as to how to staff it. And what Jay mentioned about that MLP 3.0, that's what we're pushing for next, is what in the next iteration of medical legal partnership that we're going to do to continue to better staff medical legal partnerships. We also understand the benefits, right? I referred to lawyers in residence. Perhaps you're building it as direct services or contracting it out. Now we finally have a sense from those over 450 medical legal partnerships, again, how to build it. What do the variations look like? These are just 2 of the pretty much staple models that we've seen, but at least we have examples to learn from. So we're getting stronger and stronger as we head into MLP 3.0. We also understand what it means to share information. Lots of privacy questions came up, how to share data between the different types of partners. The folks who've been running MLP over the years, they knew that this would be a hurdle, and they managed to get over and past it. We continue to hear from newer MLPs, and I promise you, we've got the data finally and the best practices to be able to finally say, okay, we know how to build this. And this is because of you all. We've also identified some best practices for screenings. We know there are about 4 different basic approaches, and I'm sure there are more. And we also understand more about how to pay for this thing called medical legal partnership. There's a whole lot more to learn in this space. I think there's also a whole lot more to experiment with and be creative about in this space. And I keep going back to what James mentioned earlier about going to the policy level to try to get those bigger investments from the feds or from the state to be able to scale the model. Now's the time. When else will we do it? It's a pandemic, and we saw how the pandemic really unveiled and uncovered everything that we've been trying to address in piecemeal up until that time. All right. We also know how to build that statewide model. So if you're going beyond the direct services and you really want to say, okay, I'm one legal partner, I've got a lot of legal deserts, right? How do I really scale this thing at the statewide level? We have a state that has shown us how to do it, and there are others who are tapping into what Montana has learned. But where are we now? I think we're really in the phase where we're further demonstrating, I should say, our impact as well as our agility. I really want to stress the agility part, because here we are, really a once in a lifetime event where we're going through a pandemic. And I thought previously events such as major hurricanes or fires or 9/11, those were events where we saw, okay, MLPs really stepped up. Who knew we would have COVID-19 in the year 2020, where MLPs quickly adapted to the circumstances and needs of the field. And we know there's not enough legal services out there to address every single need, but that's why we have to scale. And really, I love what Autumn mentioned about documenting everything you're doing now, because this is how you're going to say, we've proved our impact, we've proved our agility, but there's such a great need. We have to get those investments to continue getting this done for all. Where can you go to show all of the past research and data? I'm not a researcher, and I greatly appreciate the researchers that are out there who have done the work to really experiment, run those trials, study what's going on in the field, and study its impact. And so we did publish very recently in October of 2020, an updated literature brief to help people really say, okay, what is the science out there and the research said about the impacts on patient well-being or any sort of impacts on the healthcare workforce? That's already done. In my hopes and dreams, right, as we build MLP 3.0, sure, we're going to continue to do research, but I would love to support the folks who are ready to just move forward on the experimentation, the action. Grab your researchers along the way, because what we've also learned is how to do the evaluations. What we also know is successful, and I really wanted to highlight this because I'm speaking to Connecticut, right, is that populations over the years that have been targeted, and you've done it well to address the needs of specific populations. So many of you may be very familiar with the issue brief that's on the screen about the Connecticut, New York study on veterans and the significant reduction in symptoms related to mental health diagnoses such as anxiety, post-traumatic stress disorder, as well as access to housing supports, and then receiving treatment for conditions such as substance use disorder. So kudos, great job, because we are able to use this as well at the National Center to prove the case. Similarly, during COVID, we saw, and this is where the agility comes in yet again, right? We saw immediately that civil legal services attorneys were able to adapt to the circumstances. Many of the civil legal services attorneys who are working in rural or frontier portions of the country already worked remotely, so the adaptation was pretty swift for them. They already knew what it was like to have a client 200 miles away, perhaps, because of that distance in a frontier or rural area. And similarly, right, even if you were in an urban area, we saw legal aid attorneys really step up with their legal partners in these medical legal partnerships to address several needs. And we saw it, of course, in the eviction crisis. The housing crisis in America pre-existed COVID. This is why I say MLPs are unique and ahead of the curve. You already knew what this would look like. And so what it was a matter of was adjusting to the volume. Document, I'm going to stress it over and over again, what Autumn mentioned, you have to document what you've been doing, because if you are making the case for those investments, you're going to have to talk more about the volume. You can say you can get it done, but you can't get it done for all unless there are those investments to be able to scale up. And of course, if we look at the pandemic, yet again, who is affected first? Individuals who were isolated and by themselves in nursing care facilities in Washington state. Older adults who are living alone, are particularly socially vulnerable, and medical legal partnerships have, prior to COVID, stepped up to respond to their needs. We knew that older adults typically don't seek legal help, because if you're like my parents, you may not know what a legal need is. And then secondly, you might be a boomer like they are, and they're a little bit stubborn and they think they can do everything themselves. And that's okay. That's okay, right up until, right, that legal need is something you can't address yourself unless you're a lawyer. And my parents are not. You probably won't be able to resolve that problem that you think you can address on your own. And that is in fact the case with a lot of older adults, right? We see them dealing with their problems on their own. They don't know where to look for resources. Think about access to the vaccination appointments right now. Everything's online. I was up at 3 a.m. one morning a couple nights ago, so I'm still a little sleep deprived, and I just by sheer luck alone managed to get online and book appointments for my parents many states away. Similarly, in this COVID-19 space, this is where I say MLPs have been ahead of the curve and agile. They quickly stepped up to really move from patients to policy work. And we saw from Texas actions taken by MLPs to really push for those state level petitions and directives to prevent those utility shutoffs, which we knew would have an impact on COVID and health. And we saw legal health in New York City also step up and get legal or legislative and regulatory changes, as well as other MLPs around the country. All right, so where do we go from here? Where do we go from here? This is what MLP 3.0 is really about. This is why we're gathered here today to really talk about where MLPs are and how they are poised for the post-COVID-19 world, because we will get out of this pandemic. MLPs have already had the rapport, the relationships, the partnerships, right? You've already spoken to the ACOs, HCCNs, the health centers, the hospitals, the foundations. But I put these gray dots in here because as we think about moving forward and we've documented and we've identified the need for further investments, we've identified who is really, really impacted when these tragedies occur, like a crisis related to a pandemic or forest fires, or entire communities may face some sort of housing crisis because of lead or otherwise. What else are we going to do? Who else are we going to fill into those blank spots next? Joel and I were emailing one day. Joel's our co-director here at the National Center. You all may know him very well. And he said something in an email really back in mid-December. Everything's all a blur now. So the context was probably around just the fervor and anxiety, not knowing about what was happening in our political environment, or what was happening because the elections just kept dragging on and on and on. And we could see, right, and hear from the MLPs around the country about like the need to move forward. We heard from the medical field and medical partners about wanting to break out of what seemed to be a stagnant space, that revolving door. Ada, I think, referred to it as the problems that weren't addressed. When I was in civil legal services, that was frustrating to me, and I called it the revolving door. Help a client with one problem, they came right back in with another problem or a different variation of the problem the next day, or a repeat. So here's what Joel said. And I asked him to turn it into a quote because I thought it was great. He said, the deprivations we're witnessing are not merely a result of COVID. We know this, right? They're the consequence of long-standing systemic failures that COVID simply makes more visible to more people. And as a result, our nation's interventions must be designed with the systemic failures in mind. And for us here at the National Center, our programming must be geared towards helping you all as medical legal partnership practitioners and partners convert any indignation that you may have into action. As he said, and I totally agree, this can be and needs to be an inflection point. I'm hoping that through the Q&A, you can help me figure out where we go next with MLP 3.0, because this is our moment. This is our inflection point. Thanks, Jay. Oh, I'm ready for questions.
Thanks.
Oh, Alice, okay.
Thanks,
All right.
Bethany. That was awesome. We have one question so far in the chat, but we'd love to hear others. Dr. Kristen Wagner said, can you discuss the options for healthcare providers who see the value of working with the legal team, but is not at a healthcare that already has a formal MLP?
Yeah, so I think number one, in the state, in every state, that's why I mentioned that pie chart that showed 49 states and DC. I believe there is some form of medical legal partnership in every single state. As you are in Connecticut, you have both a long time, decades long medical legal partnerships that have been operating. And that's why I highlighted Connecticut and New York's Veterans Legal Study. The point I'm trying to make, in addition to others who are a little bit newer in this space, is that you have folks right there to partner with and learn from. So number one, there are far more healthcare providers than there are legal providers. So there's an incentive to also making sure you speak to other medical legal partnerships in the state, because you don't want to inadvertently divert like resources. The civil legal services are notoriously underfunded. So you want to do your best to make the best out of really just scarce resources, especially on the legal side. So number one, reach out to existing medical legal partnerships. See if you're crossing over, overlapping in terms of the geographical area. If you're at a hospital, I would say talk to primary care providers and like your FQHCs, because you want, I think the beauty in the partnership is that you could have a legal partner or set of legal partners, as well as a broad swath of healthcare partners. So they're really thinking about how to build a robust medical side as well as legal side. And the question that often comes up from the healthcare, partners down throughout the process, and we do have toolkits, by the way, at the National Center. So I'm trying to say, use your local resources, your brain trust in Connecticut first, but sure, the National Center has really culled from the field to create the resources that you see on our website. But what I'm suggesting is consult with your, not just the formal MLP partners, but the partners that you collaborate with these very scarce resources in the state. Hopefully that helped. I'm very democratic in my idea of partnership, right? And I know that our fields can be very siloed, and we like to, hold tight to our ideas because, quite frankly, the funding world, so it's just not really, I don't think there are models that are well suited for nonprofits. If you want to get real change done on social determinants of health and social justice, you don't treat it like for-profit competitions and contests, right? You're trying to help people. So I think there needs to be some change as well in progress in our funding models. So I know it's not a Pollyanna environment, but I do encourage folks to consult with each other.
Great, thank you. Jay, did you have a question?
Yeah, thank you, Bethany. As expected, really terrific presentation. And thank you for referring to Jack Geiger too. Having done this medical legal partnership work for almost ever, I would, ingrained in my head over the years is your predecessor, Ellen Lawton, and all the colleagues before, really reinforcing the notion of what a pioneer he was, and really a champion of true kind of equal health, if there is such a term, right? Under the law and under the umbrella of medicine as well, and he'll be sorely missed. I want to go back to the evaluation / ROI question, because that's always, our partners know that, and I see some of them here, and we've always worked on that question for years, and we think we know how to demonstrate ROI in a kind of segmented fashion. But you and I had this question, I think about a couple months ago. Is the National Center doing anything, again, on the macro level to look at paradigms or models? Because, one of the hardest things I think that MLPs work with is this notion of evaluation is very expensive. And the National Center spent hundreds of thousands of dollars years ago on an evaluation, and it can be a double-edged sword, so to speak. So, is the National Center kind of working towards a paradigm or model for ROI evaluation? We think we know how to demonstrate the impact of outcomes and stories on a micro level, and we certainly enjoy our systemic successes. But what is kind of in the field ahead, if you don't mind elaborating on that for a few minutes?
Yeah, I think I appreciate you asking. And again, I mentioned that I'm not a researcher. So the folks that I usually talk to about exactly that are Joel, as a professor, who also say he's not an evaluator. And then we have Danielle on our team, who's an MPH coming up. So yes, I can say yes, that's a part of MLP 3.0, because we know that, yes, there've been a lot of resources poured into really evaluating both quantitatively and qualitatively the impact of medical legal partnership. this is why I mentioned like, funding models. I think it's very, very important to continue to talk about the qualitative impact and tell the patient stories, because you may have a situation like Dr. Brenner's program where, a study comes out and says, well, we couldn't really find the true like ROI in the monetary quantitative sense. I think that study came out at the beginning of 2020. And it felt like a little bit of a burn. It stung a little. However, if you kept reading through the study and the notes to that research that was done, I do believe the authors made comments to ensure that people understood that it's still worthwhile. The qualitative impact is still worthwhile. But in fact, those are the sorts of conversations I've been having with folks in the field. Yourself, Jay, we have James Tufel, who's also a researcher, and he specifically focuses on, and you'll see his name on several resources that are on the National Center's website, but those are actually ongoing conversations. Since they are ongoing conversations and Jay managed to open the door, what I'm asking for folks to do is please, please, please let us know. And we have heard actually from folks in Connecticut about research that they are doing on impact. At GW, I've had conversations as well with some of GW's researchers just to try to get a sense of like, what's the right way to look at this, right? I know we've had questions about the ethics involved in doing like randomized control studies, leaving some people out of services that very well they need and some people in, right? So we know that there have been long like ethical dilemmas around that. But then there have been separate conversations about whether you look at ROI at a community level, localized, very localized in scope, or do you look at it more broadly? And like, how do you compare that? So those are conversations underway. And Jay, I don't know who can help me coordinate this. I know Yale folks are on here because James is there. James knows I've had Connecticut James, also knows that we're thinking about exactly this, the research. So I'm looking forward to, because it's our action year, right? I'm looking forward to actually, as a first step, everyone answering the survey that we'll send out to the field to say, who are you and what are you doing? Then we'll get a sense of exactly how do we target and structure research around return on investment or other types of impact and evaluation analyses. I can't remember, but I think I pulled a slide that I had in here about evaluations, and I'm happy to share it. It's a part of some other issue briefs, I believe, that we have online.
And Caroline, did that answer your question as well? You had the ROI question.
Right. No, I did. Thank you so much. It's really helpful. So, we're in a position that we could probably get philanthropy to help get a program up and running. And at some point, the folks at the hospital will look at me and say, and so, we can't support this forever with philanthropy. How are we going to make sure we support it on an ongoing basis? What's the ROI here? And, I'm convinced there is one. I just getting my hands around it.
I got what you're asking. Yeah. So if you're looking at the more specific level, I think I may have pulled a slide. Actually, I think I had two slides. I had a slide that talked about evaluation. I'm happy to share it, Jay, if we can disseminate it afterwards. I just had to cut down on the slides that I have. So number one, and we see this especially like in the health center when we talk to health centers about how to really structure their funding. They're philanthropic investments, sure. Hospitals as well, right? They may use their community benefit dollars to really support that initial investment. Keep that, maintain that, because if you're looking at things like an intervention that involves getting someone Medicaid or some sort of health insurance coverage, track that individual's costs, like uncompensated care. I think there's a new dollar amount out about what hospitals are at right now because of COVID in the billions of dollars. I think it's 600 billion over the last 10 years, but they got a new number out because of COVID, right? So what you're showing is, especially, this is where I think hits home, is when you talk about uncompensated care. So if you focus on saying at the simplest level, right? Here's a legal intervention where the individual, as I showed on like the legal needs slide, income support and insurance, health insurance can make all the difference in the world in terms of accessing care as opposed to going to the wrong place like the emergency room and driving up costs. We managed to, through the legal intervention, get that person health insurance the hospital partner on that side, part of the MOU will involve some data sharing and tracking, right? You say that part of our MOU is to track what the dollar amount and health impact is for that patient. Are they no longer going to the emergency room? Are they now accessing primary care? Which is why I also suggested that, if you're a hospital partner, you should probably also like partner with primary care in the community so that you can look at that patient, putting them at the center. And then furthermore, right, then you look at over time, right, what would that person have cost to that healthcare provider if it were to amount to uncompensated care? And it's not just about like what their condition is. Remember, a condition is probably likely to be exacerbated because someone didn't take care of that condition. And we certainly have impact studies on that because they didn't have health insurance. So I wanted to highlight the health insurance piece, but I'm happy to share the eval stuff. There are issue briefs on our website, but that's the easy to grasp example. And just remember, those hospital and healthcare providers are always talking about value, 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 which I think is the most vague and ambiguous statement. Learn to speak that language. Usually when they're talking about value, they're not just talking about health outcomes, but they're talking about savings, revenue for avoiding things like uncompensated care.
Thank you.
I had my old state policy at NAC hat on because that's all we thought about: Medicaid coverage and payment and looking at APMs and yeah. So that's the easy one, but there are other ways I think to get to ROI as well.
Does anyone have one last question? If not, I do. Bethany, in light of the new president and the new administration and the focus on, and his real, very clear focus on health equity and racial and ethnic justice, what is the National Center doing at a federal level or at a systems level to work with the administration and to think about how MLP can participate in that work, both locally but really as a national movement to push that envelope, as we've seen so many disparities come out during COVID?
Great question. So in some shape or form, over the years, the National Center, because I get to look at all of the treasure troves and chests in Dropbox. I know that the National Center has been involved in policy work, right? We know that, I can't remember exactly what year, but there was a push even at the federal level to see if medical legal partnerships could be put in statute and ingrained. And I believe there was a Hill Day event, right? So that's one example. Fast forward to today, while we don't have a policy shop, I come from a policy shop. And so I'm still on the lookout for, and have shared, for example, that I think right actually before the administration came in, CMS shared I think it's a 51-page state health officials letter to really kick off 2021. And it was specifically to address social determinants of health and the ways Medicaid and CHIP could really be utilized to push forward those efforts. So what else is the National Center doing? We are in this different sort of space, being at GW, and we're not, lobbyists or policy folks, strictly speaking. But what we're doing is first, this is why I suggested that we want to hear from you, because we want, number one, we want to know where you're weighing in, especially to state level, because that's where, we are less connected. And number two, we're sharing information such as what folks may have picked up on. The VA managed to get VA MLP really ingrained in two spots, the NDAA and then the larger piece of legislation. Both were passed. They're unfunded mandates, but we just spoke to the VA folks who lead MLP just yesterday, and they're really excited to move forward. And one thing that I did offer to them was that, there are MLP folks around the country who would be happy to serve as an advisory or focus group or brain trust to help them work through the formation of or the promulgation of those regs, and really bringing together or putting some meat on the bones of what VA MLPs can get done using that federal legislation. So those are just a few quick examples, Alice.
Excellent.
Well, thank you, Bethany.
Thank you.
We very much appreciate your presentation in and the only way we can do this in 2021 with a kind of a standing ovation, but on behalf of, I'm sure, folks on the call, we really do appreciate your wisdom and your guidance, and we really look forward to working with you on the next phase of MLP. I think that you captured this incredibly well. If not, the expression, if not now, when, right? I mean, this is the time that we as lawyers, we as physicians, we as clinicians, as folks who are advocates can seize the day, right? This is the time. And I think we're very uniquely situated as medical legal partnerships to be on the ground floor of that kind of change-making wind, if you will. So thank you again. We appreciate it. So now here's what I'm going to do. We are going to shift to the next part of our program. We have two breakouts, and I'm going to briefly just describe them, and they should have been on the agenda, but we are at the breakout session part 1, which is ethnic disparities in the COVID-19 era, how partnerships have adapted. So we have starting up and integrating an MLP in the age of COVID, which is led by a couple of folks from Greater Hartford Legal Aid and some of our own folks from our medical legal partnership, and also screenings and data collection, which is going to be led by folks from the Connecticut Veterans Legal Center. The way we're going to do this is I am going to stop the share, and we are going to allow folks to choose your own breakout rooms. This worked 4 times yesterday, so let's just hope it does it again. So I'm going to allow you to open the rooms, and then you choose. If you cannot see an icon that invites you to choose a room or something pops up, then send us a note in the chat and we can assign you easily. So I'm going to do that right now. We'll start the breakouts in a minute or two, and those will run for approximately 40 minutes. We'll come back to the main site. We'll give you a 5-minute warning, and then we'll do it again for the second set of breakouts. So here we go. You should see an invitation, and you should be able to choose a breakout room 1 or 2, and then go ahead and choose that. And we'll remain in the main section 2 for those who want to come in and out and ask questions. I will certainly be here wandering around into the rooms, but anybody who wants to stay in the main room will be here as well.
I'm not seeing anything, Jay. Are we supposed to be seeing something by now?
Yeah, did you, I can assign you, Priya, no problem. Just let me know if you want to go into room 1 or room 2.
I also don't have an invitation. I need to go into room 1.
Okay, so let me do Priya
Room
first.
1.
Room 1, you got
Yep. Room run.
Going with her.
it. Shelley, you as well?
Yeah, number 1, I guess.
You
Thank
got
you.
it.
Gunjan wants room 2.
Now we got it. All right.
Hi, Jay. I'm Christy.
Hey, Christy.
You got to stick me in room 1.
I do. You're not seeing anything either?
No.
All right, no problem. We can do this. We have the technology. 2, Gunjan, you got it.
Okay, Jay, it's Christy Fisher. Could you put me in room 2?
Sure.
Thank you.
Hello, Gary, room 1, please.
John D'Ambrosio wants room 1 too, Jay.
I gotta get Gary first. Gary, what did you say?
Room 1, please.
You got it.
Thank you.
Is everybody else still without? Bonnie, room 2, you got it.
Yeah, it's Carolyn at room 1, please.
You got it.
Thank you.
I've had a feeling you'd be in room 1.
Yeah.
Jay, Debbie's going into room 2.
Okay. Debbie.
Nan into room 2.
Who's the
Thank you.
next one, Kiana?
Nan.
2.
Yep.
You got it.
Amy is going to room 1.
Amy is going to 1.
Can you do John? He's been waiting a while to room 1.
John D'Ambrosio,
Yeah.
we'll get there.
Well, he was,
Molly into room 1.
Julia into room 2.
What's that?
Julia into room 2.
Julia into 2. You got it. Linda, which one would you like?
I need to be in room 1.
You do indeed.
Thank you.
Ryan Powell in room 1. Andrea into room 1. Darren in room 1. Derek into room 2.
Darren in 1.
Darren in 1, Derek in 2.
Great. I think that's it. Andrea? I don't have.
Andrea's into room 1.
she wanted room 1.
All right. Oh, so she can switch, I think, if she comes back in. You can do that. Anybody else?
That's it. That's all we have for now.
Nathan, Claude, that's it? Okay.
They probably stepped away. All right, I'm
Yeah.
gonna go, or do you want me to stay?
You can go. I think we're good. It wasn't as bad as I thought. Just took a couple minutes. Good.
No, but just to be clear, it came up on my thing right away.
Yeah,
Yeah,
I didn't get it. I didn't get it still. So I guess some people get it, some people don't.
Yeah, I don't get
I
it
wonder if
why,
it's-
but you know what? But you didn't get the ability to assign people, right? Only the host can do that. All right,
No.
so we'll do the
Yeah.
same thing. We'll give a remind me. We'll give a 5-minute warning in at 11:05.
Okay, I'll put
Well,
my
a
timer
little
on.
after 11, so we'll kind of fudge it a little bit, but we'll make some time there.
They'll come back into the main room and then we'll have them go into the breakout rooms again.
Yeah, and then we'll close the rooms, and they'll come back in, and then we'll give the choices again.
Okay.
All right, good work. Thank you, everybody.
I'm gonna put my timer
Same
on.
to you.
You got it.
I just don't know how to go into any breakout rooms, so I'm gonna hang out here.
If you want, I can assign you.
Okay.
You want? I mean, I think, so just let me know. Do you want to?
Yeah. Yeah, if you can put me in breakout room 1.
Yeah. All right. Let me know if you can't get out, if you're stuck, just text me, Ken, okay?
Okay.
Good.
It was very valuable.
Got to celebrate those victories. Christy. Hi, everyone. My name's Christy Mills. I'm a licensed clinical social worker, and I'm the program coordinator at the Yale Child Study Center's Outpatient Psychiatric Clinic for Children. Good to be with you today. Carolyn?
Hey, good morning, everyone. Carolyn McKenna. I'm the Chief Legal Officer for Nuvance Health, and we're a 7-hospital system that is half in New York and half in Connecticut. We do not have an MLP, but I'm exploring setting one up. So I appreciate you having me here, and I'm interested in learning from all of you.
Gary?
Yeah, hello, everyone. I'm Gary Zaremski. I work part-time now as an educational surrogate parent with the Connecticut State Department of Education.
Thank you. That's super important, as we all know. It's a very important role. Amy?
Hi everyone, I'm a third-year law student at UConn Law, and I'm a legal clinical intern with CCA this semester and last semester. So I'm happy to be here with you guys.
Molly?
Hi, good morning, everyone. My name is Molly Franco. I'm a prospective MSW graduate from the University of Connecticut, and I'm interning with GHLA.
Now, John is on my screen. I went to college with him, and I didn't know I'd be seeing him on my screen. So, hello, John. Welcome.
Okay, how are you? So I'm John D'Ambrosio. I work at Hartford Healthcare now in their in-house legal department, and recently volunteered to take on coordinating our MLP with GHLA. Because in private practice, I actually had worked with Rich, and you know, unfortunately was looking forward to working with him again. But now I'm looking forward to working with the rest of GHLA and coordinating the process there with them and our health equity team.
Great, thanks, John. Alden?
Hi, I'm Alden Pinkham. I'm a legal fellow with Connecticut Veterans Legal Center, just started a couple of months ago, and I'm working on helping our clients with some access issues.
Student this semester, unless I've got that wrong. And I just want to also say Nan Baker is here from Haven MLP, which serves undocumented, uninsured patients out of a sort of community health center that's run by medical and law and public health and nursing students at Yale. And she's going to be talking later at noon about some of the policy work that they have. And then I also see Dr. Silver here, or at least her profile picture.
Yeah, and I wanted to say hi because I have a mask on and I'm seeing patients. So if I seem less than responsive, that's why. But I am really interested in learning and hearing everyone's experience in between my other part of the job today.
Yeah, and just so folks know, Dr. Silver is working with us to expand MLP services at Yale New Haven Hospital to breast cancer patients, and then ultimately to hopefully all cancer patients. And we are hoping to hire a fellow to help us do that work with Dr. Silver in the next year.
I also just want to give a shout out to Dr. Silber for her commitment to this work and to addressing social determinants of health for years. So she's one of these champions, medical champions, who just keeps talking about it. And hopefully, Dr. Silber, everyone's listening now.
That is so nice. And I really appreciate that. And just seeing what's happened over the years is really exciting. This is a great time to be doing this work.
All right, is anybody else? I think I've listed.
My name is Dina. I'm a social worker at Hartford Hospital. I'm one of the two social workers kind of championing the MLP here. We've been in existence for just over a year. And unfortunately, one of our two attorneys that we've been working with was Richard Patakula. So we're really feeling that loss. And he was a major driver for this project. So to a certain extent, some of us feel like we're kind of starting fresh, but I'm happy to be here and I'm so excited to learn from everybody.
Hey, Rebecca.
Hi, how's it going?
Good to see you. How's it going?
Good.
We're in the breakout sessions now, so there's two choices if you'd want to join. We probably got about 20 minutes left in the breakouts if you want. Then we'll be going to the second one.
Yeah, that sounds great. Thank you.
So there's two choices. There's starting an MLP or there's data and screenings. Those are the two choices.
I will go to data and screenings.
You got it. I will assign you there.
Thank you.
You're welcome.
Hello.
Hello.
Hi, this is Dave Rosen from North Carolina, zooming in.
Oh, how are you? Can you see the breakout sessions?
I can't. I don't think so.
All right.
Let's see. I see the screens. I see you, and then I see Nathan Lays, and then Claude Mayo.
Yeah, but you don't have a little icon that says breakout rooms?
I don't.
All right, there's two. I don't know if you heard me talk to Rebecca. There's starting an MLP, and then there's screenings and data. Those are the two that we have.
I think the second would be most appropriate for me.
Screenings and data?
That's right.
All right, I will send you there right now. Thanks very much.
Okay, thank you.
Some direct representation during the pandemic, and just going back to that particular person that had a criminal issue, we have now connected with the public defender's office where we can do a warm handoff saying we have this person at the either in the hospital or outpatient that has this case coming up. Could you help them? A woman just, I don't know if it was Friday, she had court and her case was dismissed. So we've had about 5 people get their cases dismissed through the medical legal partnership, having that warm, that connection with the public defender's office.
That's pretty powerful stuff. I mean, like you said, how do you quantify the impact and especially the piece that you gave that woman at the end of her life? So Christy and I are going to talk a little bit about our experience. We are even newer than Linda. So as I mentioned in the chat before, I've been an attorney at CCA for about almost 12 years, and I've been mostly in our Bridgeport office for that time, doing educational advocacy, which has kept me very busy, as you can imagine down there. And so when we finally were able to kind of get the ball rolling on a medical legal partnership with the Yale Child Study Center, which Jay and particularly a law professor at Yale Law School, Ann Alstad, have been working on for a couple of years. This is kind of their brainchild. Christy and I are carrying out their brainchild, so hopefully we do them proud. But when I got involved about last year, Jay said, you know, I think this is a really great fit for you. And it's just been, you know, it's been a journey, but it's been a really exciting journey. And I'm really grateful for it. So talking about a little bit of the, I guess, the nuts and bolts, you know, when I was looking at the chart, and again, all the lingo is still new to me, you know, and all yeah, all the kind of terminology is still a little bit new to me, but looking at the pie chart that we had in our keynote this morning and looking at the different kinds of facilities that have medical legal partnerships, we are told that we are the first medical legal partnership in a children's behavioral health setting in the country. Right, Christy? That's supposed to be our claim to fame?
Or at least among, right?
Yeah.
There is apparently a program that has a medical legal partnership with a clinic for undocumented children in New York, but it's a very niche kind of population. There does appear to be at Bellevue a medical legal partnership. And while it is described as being in a behavioral health setting, it really seems to me when you read the articles about it that it seems to be a hospital setting. So it's behavioral health as it exists in a hospital and not necessarily as it exists in the community. And so I think we are a little bit different. I can tell you a little bit about the Yale Child Study Center. We are a organization that is the Department of Child Psychiatry in the Yale School of Medicine, but we are also an ambulatory behavioral health clinic for children for Yale Medicine. We hold multiple licenses, both for children and adults, and we have a number of outpatient and community-based, as well as hospital-based programs. Our two hospital-based programs are a children's inpatient psychiatric unit and a children's intensive outpatient unit that serves children about 6 to 12. Both of these programs top out at about 12 or 13. Our outpatient clinic is a licensed behavioral health clinic in the state. We serve children from 0 to 18, and we also hold an adult license. The adult license is a unique one. We opened an adult clinic because we were having difficulty finding well-integrated trauma services for some of our parents. And so we wanted to kind of hold a focus not only with their mental health care, but with their parenting. And that was, believe it or not, a kind of unique angle. And so we created a clinic that does a little bit of that. We operate several, this is maybe a little too much, but we operate several specialty units in anxiety, autism, trauma, TIC OCD. And for those particular specialties, people come from all over. Our largest clinical services, though, are our outpatient clinic. We have about 1,500 kids active at any given time. It's about 80% Medicaid. There are a couple private insurances in there that we accept. And we have a fairly large set of community-based programs that go into the home that sort of range in terms of what they provide to families. And so that's the setting. And so I think Catherine is correct when we say it is a unique setting for a medical legal partnership. Most of what we read has been in primary care or hospital settings where medical care is the focus, and where when you're evaluating outcome, you can use things like ED visits, decreases in number of visits to your primary care doctor. I think Catherine and I'll have to look carefully at how we measure outcome, because it's not exactly comparable. So decrease in visit isn't necessarily a sign of success in our setting, right? We want people coming and caring for their mental health. But decrease in sort of psychiatric referral to emergency room might be something we can look at. But I'm also interested in trying to find sort of other measures of outcome that sort of look at the broader impact across our agency. So I could tell you, I'll pause there in case there are questions about any of that, but I can tell you more, and Catherine and I will tell you more about how we focused our time as she begins at the Child Study Center.
Yeah, I think folks can see how thoughtful of a partner Christy is, especially for, we feel like kind of the train had already left the station and we were both like, wait, who started?
Hey, Casey.
Hi, sorry, I had to drop off for another call.
Were you in one of the rooms?
No, I just had to leave from 10 a.m. to now, so I didn't join.
Do you have a little icon that allows you to go to one of the rooms somewhere? It says breakout rooms or something?
It says, please wait to be assigned.
Oh,
So I
okay.
think I just haven't been assigned.
All right. So the 2 breakout rooms that have about 17, 18 minutes to go are starting an MLP or data and screening.
How about starting an MLP?
You got it.
Perfect.
You got it.
Great, thank you.
I think is great is what people's access to technology is. So, we've been asking, like, do you have a cell phone? Do you have a this? What do you have at home? And I think that's been really important.
Yeah, we added that with COVID. Thanks for bringing that one up. It helps us determine how to communicate with our clients. Can we send an email and know that they'll get it? That kind of stuff. So
I think that's one of the big barriers that we have is not only do we have a technology barrier, but we also have somebody who is usually quite sick. And sort of the last thing on their mind is trying to, they're really focused on, the addressing the existential distress of dealing with, their final affairs sort of thing. So, they don't, so we sort of keep everything to a minimum of just getting them to that end game. And we haven't really, it's hard to ask them for something more than what they, really, really need and want.
and under. I've worked with all ages. I was originally a fellow at the Child Studies Center, but I am endorsed as an infant mental health mentor, which is Connecticut holds an endorsement in infant mental health. And as I was listening, I say all this to say, as I was listening to Bethany, the one area that was not on her slides has to do with the mental health of infants, toddlers, and the interaction in early life parenting. And so I think that's something for us to pay attention to in the future. But Catherine, one of the first consults you got was around a mother who had very diligently been paying for rent all through COVID, even though, she could have taken a break under the current legal status. She really didn't want to. She felt like her landlord deserved her rent. She paid her rent until she could no longer pay it. And she is the mother of a teenager who the family had come from Puerto Rico, and the teenager had been sexually assaulted in Puerto Rico. And so they had paid their rent as long as they could. And she really had then sold her furniture in her home to pay her last month's rent and was going to be unable to stay because she did not want to say to her landlord, I cannot pay rent. And so one of the first consultations we did was around seeing if we could get her to even imagine having that conversation to buy herself 1 or 2 months worth of time while we applied for some other things. And so can you talk a little bit about that one?
Yeah, I mean, I think, a part of that was talking about mom's legal rights, but then it was a lot of counsel, right? It's like, these are your legal rights and you are free to exercise them. And, you've been so diligent in trying to do the right thing, but these protections are in place because we're in this crazy time and everyone is struggling. So I think that was kind of imparting some of that counsel. And then we were able to kind of talk to her about how to approach her landlord. And I think, she was able to work with a landlord who ended up being very reasonable and receptive. And I think that was particularly important because, as Christy kind of mentioned, if they weren't able to stay in this home, there was the thought that they might have to return to Puerto Rico, and that would have been extremely traumatizing for the child. So I think it's a great example of a mom desperately doing everything she can to keep her child in the best position. I wanted to quickly mention, and then I want to make sure we go back to Linda. I wanted to quickly mention that. So all the attorneys at CCA, we all do individual representation, systemic advocacy, and community trainings. So we all have an individual caseload. We all do, a great deal of systemic work. So now that I'm with the Medical Legal Partnership, it'll be tailored in that direction. But by systemic work, I mean, we sit at a lot of policy making tables. We write legislation. We file systemic litigation. We write systemic complaints to different agencies. And I just think it's important that, I really wanted to impart that to my new colleagues, because I wanted them to know that I don't want them to think it's just every case that comes in front of me. That's not the only thing that we're able to do. We're able to try to make change that's going to affect all the kids and all the families who are in particular classes of people that we are working with on a systemic level. And I know a lot of my attorney colleagues here, understand that well. And then finally, the last arm of training. And so we've always been very dedicated to training community folks, parents, children about their legal rights, especially, and providers. And so I've always done trainings to child and family guidance down in Bridgeport, and care coordinators and favor or probation officers. And so a huge component of MLP, which I'm seeing more and more, is really the training arm in working with the providers to build capacity. And that's really exciting for me because there's only so many people I can talk to in a day. And frankly, I say a lot of the same things over and over again. So it's not like it's all complete rocket science, right? I love to share more with the providers who are going to, really enhance their ability to know that next step, maybe from this step to 2 more steps, and then maybe, connect with me. And again, Christy's been really thoughtful, and let's make sure that we are having our providers do as much as they can, before they get to the point where they reach out. So we have 10 minutes. I want to make sure we circle back to Linda and then to questions. Linda, is there anything you wanted to add?
The only thing that I wanted to say, it's also to have good community resources to be able to, like, when people need food, to know who's distributing food. There was Hartford Communities That Cares in Hartford that was distributing food, and we were able to partner with them, and they were able to provide food to several of our medical legal partnership patients that were homebound. And the other thing is, I just want to say, in watching Catherine and Christy, it's really important to have a nice partnership. And unfortunately, Rich isn't here, but having a partnership and having someone that you can bounce things off with and talk to really makes the medical legal partnership work.
Thank you, Linda. And I didn't have the pleasure of knowing Rich, but I've heard from so many people what an innovative and inspiring person he was. So it sounds like he really started things off on a really exciting foot, and hopefully set the path forward. So,
this is.
Oh, please.
Sorry, Catherine, I didn't mean to interrupt. This is Giovanna, Linda's colleague at GHLA, and I think Linda and Rich really did, in starting the MLP, they really did sort of anything and everything. So you heard from Linda that they did both sort of legal needs in terms of standby guardianship or trying to do referrals to get warrants quashed, and also meeting folks' social and human needs in the midst of the pandemic, particularly early on in the shutdown when things were really sort of
Hey, Marilyn.
Hey, Jay. Good morning.
Nice to see you. How are you?
Nice to see you. I'm good. How are you?
I'm great. I'm great. I'm so glad you can help out in our second breakout. That is so cool. I'm glad you're able to do that.
Yeah, I'm happy to be here. So
we're running a teeny bit late. We push things back about 5 minutes. So the second one will probably start a little bit more like 11:25 or so.
Okay.
And so you should be able to share your screen too if you need to do that. I think Bonnie asked that. You should be able to do that within the breakout room.
How do I do that?
Well, at the bottom, when you get in the breakout room, at the bottom, there's something that says share screen. There's a little icon.
Yes. Okay.
Yeah. So you should be able to, as long as you have it somewhere, you'll see there'll be a it's a little confusing at first, but you'll see that there'll be like a choices of documents. I would open it up and put it somewhere in the background on your computer. And that way you'll see it and you just click on the little area where you see your document and then click on share and it should go right there. But I can go ahead and help you do that too.
Yeah, because I'm not too,
Yeah.
I mean, I see the share screen.
Right. But you wouldn't do it now, but when you get there, it's a Word document, right?
No. We're just gonna have a conversation.
Okay, I thought you had a document. I'm sorry.
No.
Okay, maybe I mistook. Maybe Bonnie wants to share one, so she knows how to do it. So
Yeah, no. She's just gonna ask me to sort of present like how families, usually ask for the medical necessity for Eversource and kind of talk about that.
Yep. All right. Let me.
Did I log out and
No. Stay where you are. Stay where you are. You can just hang out here, and we'll be doing the other breakouts in about 5-10 minutes. So you can just hang out here, and you can turn off your camera if you want, and
okay,
or leave it on, whatever you'd like. All right.
Okay, cool. I'll turn it.
Good to see you.
Same here.
Yeah, I got to come over when things open up again and say hey to you and Cree. I miss you guys. I know.
It's been tough, but we're hanging in there. So we're doing the best that we can.
That's great.
Yeah.
All right.
Okay.
Thanks.
Okay, you're welcome.
Hey, Rita.
Hi,
Hi.
Jen. How are you?
Good. I just saw your picture in the equal justice thing. You're getting it done. Good for you.
Thank you. I didn't know they were doing that. A couple of people sent it to me and I was taken by surprise, but it's very nice.
That is so cool. That is so cool. Yeah.
Yeah. Well, this was great. The keynote speaker was incredible.
Yeah,
and
I know.
Really good so far. I had to drop out for a bit, so sorry. That's why I'm awkwardly back off session, but
Yep. Yep. All right. Well, I'm gonna kind of do some administrative stuff, but I'm sure I'll see you later.
perfect. Nice to see you. Bye.
You too. All right, well, I hope everyone had an opportunity to at least kind of dig into some of the issues in both sessions. I had an opportunity to kind of surf between both breakouts, and thank you all for participating and providing feedback and context. We realize that it's not a lot of time, but at least it's an opportunity to get people talking about those two issues. We're going to go right into the second breakout. I know folks may need a quick break, but there is some time constraints, and we have presenters who are, I think, who are somewhat limited in terms of their time frame. So I really want to get going on that. The two sessions that you will see, and you'll have to hang out one sec, are the following. There's going to be telehealth, telelaw, and addressing the technology gap. That will be session one. And the second will be a utility case study, which will be led by our colleagues from our own MLP, which is really fascinating look at the systemic impact that COVID has had on utility shutoffs and what our team has done about that. So if you'll give me a moment, I'm going to stop the share and I'm just going to set up the breakout rooms, and I will be with you in one moment. So give me one sec and we will start that. And again, if you are not able to see an icon and you need to join, I'll go through the room and I'll assign you as is. I'm not sure why some folks get an icon and some folks get a notice and some don't, but that's beyond my pay grade. If I own Zoom, I wouldn't be doing this today myself. So anyway, I know where we're going. So we'll go through Marilyn, you're going to number 2 or number 4. Sorry about that. Priya, gotcha, number 2. Utility, right, Priya?
Bonnie, number 2, Jay. Carolyn, number 2.
Debbie Deegan wants 1 and Darren wants 1.
Casey wants 1.
Linda Allard wants 2.
Nathan wants 1.
One sec. I just got Linda Allard wants 2.
Nathan wants 1.
Nathan wants.
Rita wants 1.
Hold on. Rita.
Gunjan wants 2. Oh, Bonnie Roswig needs to go to 2.
Yeah, I know that.
Soon.
I got it. Gunjan wants 1.
2.
2.
2, sorry.
Bonnie Roswig needs, I assume, 2.
Just to repeat for someone, session 1 is telehealth, telelaw, and addressing the technology gap, and session 2 is a utility case study.
All right, Dave, you're going to 1, so that would be telehealth, correct?
Julia, 1.
Nan, I got you. Hold on. Give me a sec. Dr. Rosenberg wants what?
1.
You got it. Where am I at? Gary, what can I do for you? 1, you got it.
Please. Thank you.
Shelley wants 2.
Thank
you. Shelley wants 2. Got it.
Christy wants 1.
Christy wants 1. All right. This is really
fun,
isn't it?
Amy wants 2. Catherine wants 10.
Derek wants 1.
Amy, you want 2 utility? All right. And
Derek wants 1.
Derek wants 1. Got it.
Ryan wants 1.
Rebecca wants 1.
Rebecca is assigned.
John
did you
wants
get it,
1.
Oh, Rebecca, yes, sorry. I can't find you on there.
Rebecca, oh, it starts as Haven.
Oh, yeah. Okay, she wants one?
Yeah. And John D'Ambrosio wants one too.
Catherine, you want to hang out here or
I'm gonna hang with my friends.
John wants what? I think I just assigned him, didn't I?
One. He wants one.
Yeah, I don't see him anymore. I just assigned him, I think.
All right, I'm gonna head out. Is that all right, or you need me?
No, I'm good. I'm good. John, I assigned. Gary, did I get you?
You got him before, I think.
Yeah, I think they have to accept the.
Yeah.
So how'd it go, Catherine?
It's great.
Good.
Love talking.
Not enough time, but.
No, it's good. It actually worked out well.
It looked like it was going well.
You know.
Ours was really great too, by the way. We're gonna have a separate breakout. We're gonna talk more frequently.
You know what we're gonna do next year? We're gonna ask for RFPs, so we get to choose who does the breakouts. So we
Excellent
don't
idea.
we don't have to do it like the National Center does. We're gonna ask for people to submit proposals so we can be the big BMOCs and we can figure out who gets to go and who doesn't.
That's excellent.
Hopefully in person, but that's what we're doing. But I'm glad both sessions seem to be going well. Kiana, where were you at? Did you go to one of them?
I was in both of them. I started off in the one with Catherine and I ended up in the one with Dallas. So I split the time, 20 minutes and 20 minutes.
But I know Anna has to leave at 11:45. So hopefully Julia will take over and help her with that.
Okay. Bye, guys.
All right.
Bye.
We'll see you.
Wait, Jay, I need you to put me in Bonnie's breakout room.
Oh, yeah. Sorry about that.
It's okay.
I will do that. You're going into that one. Oh, boy.
Okay.
If she has trouble sharing the screen, you know how to help her, right?
Yeah, I think. I don't know if I can if I'm not the host. Can I?
You can. Anybody can.
Oh, okay. Okay.
Only one person, so that's good.
Okay.
Okay, you got it.
What am I doing?
Maybe you should go to, why don't you go to telehealth, because it's a lot of your colleagues are doing that, and the technology, it's really more about the technology gap too.
John, let me tell you though, Jay, real quick. It's okay to be here. I went to college with John.
Yeah, so you said.
Yeah, so he is at Hartford Healthcare now.
Kate, I've never heard anybody call you Kate.
Eddie calls me Kate.
I'll have to say this. I went to high school with Carolyn McKenna, who's the.
Okay, I know you have to one of me. You know everybody, but sometimes I get a win. Sometimes
I know this one was a good one, but I did go to high school with Carolyn, but I didn't really know her. But her brother and I were classmates. She's a year behind, so her brother and cousin were in my class, Dan and John. So, all right, I'll send you to telehealth, and we'll see everybody at about 12:05.
Good stuff. Looking good.
Okie doke.
So very curious to hear how everyone's doing this.
Gary Zaremski.
Yeah, hello, everyone. I'm an educational surrogate parent with the Connecticut State Department of Ed. And I'm not doing telelaw or telehealth, but all of our educational meetings observations, PPT meetings are all done, of course, virtual through a number of different platforms.
Oh, interesting. Attorney Rosenthal?
Hi, Alice Rosenthal with the Center for Children's Advocacy, and I run and work with Yale New Haven Health here in New Haven. And I've been doing both in person and over the phone, not really video with clients.
Attorney Deegan?
Yeah, I'm on the medical side and work at the VA, and we have a combination. We do a lot of community work, so I do still have staff that are going out in the community seeing people, and we're doing an awful lot of phone and video contacts with our vets.
Ms. Pinkham?
Hi, I'm Alden Pinkham. I work with CVLC. I'm a fellow there. I started in November, so I have yet to meet any of my clients in person or see their faces. But before becoming an attorney, I worked on a 24-hour crisis and trauma line. So this actually feels very familiar.
Attorney Iannantoni? I'm sure I've slaughtered that.
No worries. It's Iannantoni, and I am the legal supervisor of the Palliative Care Medical Legal Partnership. And I would say that I have exhausted all platforms. I do all of my private practice attorney hearings have all been on Teams or WebEx, or I've done multiple hearings that way. The students that I work with through the law school, through the medical legal partnership, are not allowed to go in face-to-face with, so we do a lot of FaceTime with the students while I'm in person with the patient. So I've done pretty much adapt. I also have done, the other thing is I do these driveway signings where on Sundays, people who have to sign documents, I throw my husband and my oldest daughter into the car and we drive to people's driveways, and I jump out gloved and masked and have the client meet me to sign, and then my husband and daughter witness in the car. So that's the way I've been.
Wow. Catherine Meyer.
I say it's a family affair.
It is.
My kids would be very useless, but I like that idea. I'm Catherine, attorney at the Center for Children's Advocacy, part of the new medical legal partnership at the Yale Child Study Center. I think we're talking about how we've been operating, been completely virtual for me, including a lot of my clients, so I've had for a long time, I guess, preceding this, so I have pretty good relationships. I think the PPT, the special education meetings we've done that have been virtual have been very challenging. It's hard to get really mad at a screen, especially if the other people are all in a room together and you're the only one alone being mad. It's also hard sometimes when they have technological difficulty or maybe pretend to, and they forget to include you, add you, send you the right link, etc. So, and I say that in jest, but it really has happened more than a few times, and it's extremely frustrating.
I hear you. Ms. Smith?
Hi, yeah, I'm a law student, second year law student at Yale Law School. I'm new to the medical legal partnership clinic here in the Veterans MLP, and also I'm in the Veterans Legal Services Clinic. So I've been doing telelaw that way. We've had numerous court hearings and meetings and medical appointments for clients that have all been fully remote. So excited to hear everyone's reflections on those challenges.
Nathan Lays?
Hi, everyone. My name is Nathan. I'm a legal fellow and an attorney in the housing unit at New Haven Legal Assistance. And I'm a former classmate with Rita and Alden from law school. We have been doing a lot of telelaw for low-income tenants, which has been, I would charitably say, an unmitigated disaster. And I'm also on a working group with Darren that of different legal services organizations trying to advocate with judicial and other actors for systemic changes.
Thank you. Dr. Rosenberg?
Hi, everybody. I'm Julia Rosenberg. I'm a pediatrician. I work alongside Dr. Fennick. I have been doing much more in person than telehealth, but really working very closely alongside all of my colleagues and thinking about which patients need follow-up and what form that can come in, especially when there's a lot of very busy families with at-home schooling and that kind of thing as well. So it certainly has been something that I've been involved in, just not as directly as some of my colleagues.
Thank you. Dave Rosen.
Hi, everyone. I'm Dave Rosen. I'm faculty in the School of Medicine at the University of North Carolina and Chapel Hill. I work with a program that helps transitions of care for people who are being released from our state prison system. And that program is just initiating a MLP. And so I'm just here to kind of learn more about the process. Thanks for having me.
I think we have a transitions MLP at Yale, so we should put you in touch with them. Absolutely. Dr. Silber.
Yeah, I do a lot of telehealth. I'm a medical oncologist at Smilo, mainly breast cancer. And telehealth has been a real double-edged kind of sword. It's really great for people who are technologically adept and well, and it's really not good for people English as a second language, poor. And you've found, or I've found with COVID, that second group, you really need to see people in person and do a physical exam, because expecting someone to describe through translation on the phone does not capture what you're going to find on physical exam. So I think it's not only the experience of the technology, it's also the translation. You lose a lot without seeing the patient.
Right, so kind of emphasizing the difference between audio only and audio plus video. In addition to, of course, what we're used to, which is in person, audio plus video. Ryan Powell.
Hello, good morning. My name is Ryan Powell. I'm a attorney at Greater Hartford Legal Aid. I work in the immigration unit, and I have a lot of indigent clients who have
be able to meet whatever arrearage, they are not going to get new housing. So it is, utilities are really critical in terms of just ongoing family stability. In the education realm for children, if a child is having struggling anyway, chances are they are going to have more struggles doing homework, being successful in school, in a household without utilities. Given that landscape, I want to talk to you a little bit about what we have done, what our trajectory has been with all the partners that we've worked with. So over here we have doctors who are worried about signing forms, patients who don't have, who aren't eligible, but who have large utility bills. But we also have some good state statutes for people who are very poor. There is protection from termination in normal times between November 1st and May 1st. Many patients don't know about this. Many providers don't know about this. So what we started to do was have a series of utility clinics, which is actually which I brought it over from statewide legal services, where I worked for many years. And in the utility clinics, we had, it was a walk-in clinic. We did it at Connecticut Children's, we did it at St. Francis, we did it at Yale. It would be a community clinic between the patients, the utility companies, and pro bono attorneys who would come in and actually do budget counselors. Because one of the issues is, how are everybody has to pay a utility bill, and how is that going to happen, and understanding the critical nature of making that payment. The other nice thing about these clinics is that we had some of our medical partners do this with us. We brought in other services for basic needs. So we brought in 211 info line and food share to take food stamp applications. I always tried to get somebody from nutrition in to work with families. It was a great sort of holistic event so that clients could really get into, again, the goal is utility stability. Kathy Flaherty, do you have any other quick comments about that and in terms of the experience or some of the outcomes? We used to do this at SLS.
I mean, I think I remember just being overwhelmed by how many people would show up at those events when we did them, and that there just had to be a better way of making sure that people could keep that very basic service of utilities on.
It's just an ongoing crisis, right? So, but on the other hand, we have some pretty good laws and regulations in Connecticut that talk about payment plans, that talk about protections, but
but we've really tried to work with the technology and the skill issues that exist individually.
Yeah, I think that's great, Debbie. I think one of the pieces that we've been advocating a lot across the state is that it's not just putting technologies in people's hands, but making sure they actually are able to use it. And I don't think we need to leave our own offices, right, sometimes to find that everyone doesn't have the same skill use of technology. So expecting our clients and our patients to be able to do the same is not realistic. but getting the state to recognize that has been a bit of a challenge. Are other people seeing other complications due to this digital divide and how it's impacting your practice area?
So at the Haven Free Clinic, we see majority non-English speaking patients. And so as someone else had mentioned, there's issues with interpretation over the phone. We really tried to push for, video calls so we could be able to see them.
Hey there. You're muted.
Hey, I had to move location.
No,
I had to,
how are you?
I'm doing well. I think this is going great.
So far, so good. It's really odd trying to coordinate this on a regular Zoom thing, and we don't have a webinar feature, so it very expensive, I think, but we had to increase our Zoom capacity. But yeah, so far, so good. It's just a little stressful, but I think we're almost at the end of the road here. How you doing? All right?
Good. Yeah. Sorry. I'm doing well. Yeah. It's, if you do have something else like this sometime, I didn't think about this before, but we once had to do a webinar type thing, and we were able to get some foundation to loan us or get us a webinar feature for that event. And I can look that up if need be at any point to see who, if you ever need it again. But
yeah,
it's going fine in this format. I think this is working out fine.
I think so too. I mean, let's hope next year we're able to, do it in person.
Oh, geez.
But if not, we can also go to the law school. We can also go to UConn and ask them to use their WebEx webinar feature, because I know we could do that. So I didn't even think of that, but we could definitely do that. But yeah, fair point. Good. How are things going over with you guys? You guys kind of hanging in there? How's your job? Are you enjoying it?
I am enjoying it. Yeah, no, I'm enjoying it a ton. It's, this has all been weird. This has been, really trying to manage all this, but it's going all right. It's going okay. I think we're all very anxious though to see one another and, actually see clients and be in the locations. So yeah. We just don't know when that will be possible to do, but it's been going good. I think, there's all like the whole fundraising side of the job and stuff, which has like so far been going fine, but like the next 6 months look like probably the toughest of the batch. So there's that. But in terms of like service delivery and like how I think the team's doing, like, I think we've adapted pretty well. And so it's hanging in there.
Good. That's awesome.
How are you guys?
Not bad. Thank goodness for the PPP loan. I have to say that the initial one, and I just got an email actually from our finance director saying that I think we qualify for the second round as well, because we did have a 25%, downturn, and we can't hold any of our events, like you guys know, the in-person events, we hold 2 a year, one down in Fairfield County and one up here. And without those are devastating. I mean, it's
true.
You can do, I think, a good online event, but there's nothing like the ability to get people in a room and kind of bully them into, having a few cocktails and bidding well over their heads on things, and those kinds of things we're missing those. So anyway, but the center as a whole is doing fine. And, if our MLP was a separate entity, we'd be doing even better. But, or the whole is sometimes more restricting than the sum of its parts. So, but, I wear two hats, so I got to understand that. So anyway, so do you want to go into a breakout room or
Okay. So I'm going to jump back. Yeah, I'm going to jump back into this room. They had no idea I was jumping out there. So, all right. Good talking to you, Jay.
You too. All right. We'll talk to you soon.
Bye.
Curious if the Rabbi Capers event was something you guys set up? Question mark. Is this something we want to broadcast more to our group and to the congregation at large? Question mark. Saw this last week, but meant to follow up with both of you on this. Period. New paragraph. Thanks. Hope all is well. Period. New paragraph J.
Which is supposed to be it's at the moment $50 a month. And the problem is that prior to 2020, I think 600 people in the entire state had accessed that program. And the reason is because no one ever told them about it. And because there was this convoluted application process for eligibility. One of the things, so what we said to Pura was, look, we talked about the amounts that people get every month in SSI or TFA or GA, and really $50 a month is generally affordable, more affordable than anything else. Average monthly bill, which has been the standard, is not affordable. So we got Pura to say that every single individual who's on any kind of state assistance, so Husky, SSI, TFA, VA benefits, food stamps, is eligible for that $50 a month payment plan. There's an argument as to whether it extends to if a household has just electric, because Eversource does. Some families have combined service, but we're trying to get Pura to say that also applies in that context. One of the things we're working on is that and again, as this all expands, right? Why anybody has to go through an eligibility process for utility programs when DSS has, Department of Social Services, a prolonged eligibility process goes on to become eligible for food stamps or Husky. So DSS already has all that data. So why would there be any barrier to getting access to these affordable utility companies when DSS already has it? So we started the process of reaching out to DSS. DSS said, oh, no, that's not what we do. And we said, oh, by the way, that's exactly what you do since you administer the energy assistance monies. Through that process, we pulled in, there is something called the National Consumer Law Center, which is the backup center for all issues of consumer law and utility law. And we said, can you come in and talk to our state regulators? Because that's what happens in Massachusetts and in other states. So we now have their expertise. So it kind of expands. The pro bono lawyer who dragged me into this PURA process is now our board member. So it has a lot of, sort of using your resource, using your expertise for so many things has really motored this issue on behalf of our patients and clients. But it's also it has broadened in terms of the effect.
Ronnie, may I ask a question? This was a great talk, and thank you for sort of using that as a case study to describe all the amazing things that can be done. How do you then sort of get the knowledge about the access to resources and eligibility out to the patients and to the clients? What's
right.
Hey, Catherine.
Hello.
All right. Well, I think we have a core group of folks left for the last bit. Thank you all for hanging in there and appreciate your participation in the breakout rooms. We're going to move to the last concluding plenary, which we have as a kind of an overview of some systemic policy and legislative agenda items that our MLPs in Connecticut are working on. We thought it would be a nice way to wrap up the session and kind of put into context the individual and training into the systemic, as I'm sure you folks have been talking about in your various breakouts. And I think a lot of what Bethany talked about earlier. I'm also mindful of the idea that Zoom meetings can be a little bit stressful and a little bit exhausting. But I take heart in and maybe you can as well. I'm not a big Twitter guy, but one of my sons showed me this following, this is a paraphrase, that appeared after the inauguration, which was if Lady Gaga, Jennifer Lopez, Garth Brooks, and Amanda Gordon can perform for the nation in 35 minutes, you can have your Zoom meeting in less than an hour. So I thought there was some import to that particular tweet. So I'm going to hand over the reins to James, who's going to take us for the next about 20 minutes or so, 25 minutes. And then I'll come back with just about 30 seconds of a concluding segment. But James, all yours.
Thank you, Jay. And I just want to be a little bit of a hype man for Jay in this conference, since he did so much work to organize this. I think today has been one of the most amazing online conferences that could possibly happen. I think the breakouts were amazing. All of you are amazing. And it makes me really sad that we can't meet in person, or at least most of us can't. And I look forward to when we can, because I think Connecticut has shown that it has an amazing MLP community, the legal people, the medical people, everybody, just amazing. So thank you, Jay. So the closing panel, we're going to talk a bit about that last part of what Bethany Hamilton spoke about this morning, which is structural change. And we're all very well educated by our patients and the communities we work in as to what the structural barriers are that people face. And we're going to have two groups of presenters. We were going to have three, but I had a little cancellation. So we're going to talk first to our next generation MLP stars, Rebecca and Nan, about their work in the Haven Clinic and some policy they're working around vaccine access for undocumented people. And then we're going to turn it over to Jay and Julia, who are going to talk to us about state level legislation that they have cooked up, which I believe is about expanding Husky to undocumented children. If I'm wrong, they'll correct me. So I would like to pose the question to, or just start maybe with Nan Baker, who is one of our law students who works in the Haven MLP. Tell us about what the MLP, what the Haven Clinic is, and what the MLP, the student-led MLP at Haven does. And then if you and Rebecca could talk about how that led you to the policy work that you've been engaging in.
Yeah, absolutely. And thank you all so much. So the Haven Free Clinic is a student-run clinic here in New Haven. We serve a population that is uninsured that lives in the New Haven area, and that is between the ages roughly of 18 to 65. In that population, we have a lot of people that have civil legal needs, and that's where our MLP comes in. We affirmatively work with people who have issues related to housing, immigration, employment, COVID-19, and domestic violence, but we see a wide variety of issues, as I'm sure you can imagine. Our MLP is slightly unusually structured. we are fortunate enough to partner with New Haven Legal Assistance. They have been our amazing partners for as long as the MLP has been in existence, and we are able to work with them to refer patients. And then now, luckily, that we have James, who are able to offer legal services in-house in these areas. And I guess kind of this will lead in a little bit to Rebecca. Part of what Haven Clinic has been taking on this last year is getting more involved in advocacy work. A lot of times we see the same question or the same problem come into our clinic 3 or 4 times a Saturday. And it comes down to kind of, as James was saying, these larger systematic issues that exist, particularly for our population, which includes many undocumented individuals. Now that we have COVID-19, now that we are moving to a telehealth model, now that we're working on advocating for our population, that's something that our clinic has tried to do more of.
Thanks. And Rebecca, could you describe the medical side, the medical, how it's structured and what you do with patients?
Yeah, sure. So our model is student-based in all respects. And so we have teams of students who see patients and then report back to an attending. We provide primary care services and a variety of different ancillary services as well, including reproductive health, behavioral health education. We have a social services department that is very well connected with different community partners and grassroots organizations. And so we provide our patients not just with medical care, but with other services as well, especially related to pandemic relief. And with our specific population, the majority, probably 66%, 67% are undocumented in our clinic. And so as you can imagine, the relief from the pandemic has been very little for this specific group. They haven't received anything in terms of cash assistance from the federal government. And so part of our work over the past year or so now is working with some advocacy groups in order to provide cash assistance, going to protests, showing up at meetings with legislators and finding ways to get cash relief or rental assistance relief for our patients and for the undocumented community here in New Haven. And so that's something that we've really been working specifically with places like Unidad Latina en Acción. That's one where we have a strong partnership with IRIS, CIRI, other organizations that work closely with immigrant groups. And so that has been important, not just as we're taking care of the medical side of things and making sure that they get the referrals that they need, making sure we've walked patients to the emergency department who we felt needed that accompaniment because we were afraid of some sort of mistreatment or miscommunication because of a language barrier. So we try to take as much care as possible when we're giving our patients medical advice and care. And so that's what our clinic does. And it's only evolved when we've seen the vast array of, I guess, difficulties with COVID testing, just generally information about access to care and treatment with regard to COVID and people who do not qualify for state assistance or medical programs like Medicaid. So yeah, that's a summary, I guess.
And tell people about the one of the exciting things that the students have been up to, because they are multidisciplinary and there are public health students involved and nursing students and social work students. A group of them, I think medical anthropology students, a group of them came together collectively, not for credit and not for money, and just wrote a white paper on access to vaccines for undocumented communities. Could you guys talk about what you're recommending, what you found?
Yeah, and I think I should preface this with saying that we came together not with, I guess, the humility and understanding that we are not the experts in the area, but we would just like to vocalize what we have been hearing from our patients and our community partners, very practical, but significant differences that can be made in order to increase access to vaccines and promote vaccine equity. And those can be things as simple as not requesting an ID at a vaccine site. We've had some patients report to us that they went to go get COVID testing, and upon not having an ID, they were turned away. And that has to do probably more with staff training at the sites than anything else, because there's no requirement for identification. But now we're seeing, in the new self-enrollment site that YNHH has put up, that ID is required. And a lot of the folks in our patient population do not have an ID. That program has kind of been not discontinued, but halted during the pandemic to get access to IDs for undocumented immigrants. That's just one example. We kind of go through the different priority groups that have been outlined by the Connecticut state. So, healthcare workers, we ask specific questions about, okay, what about the people who are self-employed but do home health that might be contracted through a company, and how do they get that information? And what if they don't speak English? And what if they don't have access to things like MyChart, which is something that YNHH has been using here? So all of these sort of questions of where it could go wrong, talking about essential workers, talking about the importance of multi-generational households and protecting those who are most at risk in those places, just different social and cultural factors that affect our patients specifically, and how to address them.
Thank you, Rebecca. And there may be some follow-up questions along those lines. Given the late hour, I do want to invite Jay and Julia into the conversation to describe, and this is a related topic, obviously, the issue of just access to health insurance that they've been working on. So Jay, maybe we'll start with you.
Thanks, James. Just want to kind of, the theme of the conference is health equity, right? It's how do we kind of change the landscape with medical legal partnerships in this area of healthcare access, health equity, health justice. And one of the hallmarks, I think, of medical legal partnerships can be taking those issues from the individual in training into the systemic, as Bethany talked about. One of the kind of archetypical ways we've tried to do that over the years is to look at legislative initiatives. And one we are currently working on with a broad base of partners in the pediatric realm is expanding health coverage through the state's Medicaid program to undocumented children and youth. And that has been really kind of a laser focus of our MLP with a broad-based coalition. So this isn't a forum on how to, how a bill becomes a law, but it's a forum on how medical legal partnerships are in fact situated in a really good place to work on systemic advocacy. And whether it's at the federal level, if you're dealing with veterans issues, or at the state level, if you're dealing with access to healthcare for children who may be undocumented. And so with Julia Rosenberg, who's a pediatrician at Yale and who introduced herself earlier, I think in one of the breakouts, and a really broad-based coalition of pediatric providers and advocates and our healthcare partners. So this can't be understated or overstated. I'm never sure how to say that, but overstated, understated, but I can't say it too much, that with the blessing of our partners, with Yale New Haven Health, with Connecticut Children's and our other partners, we have really built this broad-based coalition. And obviously everyone has a different stake in this, of expanding state-funded Medicaid to undocumented children and youth under the age of 19. And very briefly, we almost got to the end zone, as they say, a couple of years ago, but we were hit by a absurdly large $52 million fiscal note at the 11th hour, which was the state's way of saying to us, we're not going to do it. But we made it pretty far in the first go around, and we've come back with better data, better access to experts this time, 2 years later. And I want to let Julia talk about from the physician's point of view and the clinicians, because we've got a lot of pediatric providers and the Academy of Pediatrics who have been supporting this endeavor, but why the nexus and the symbiosis of the MLPs can be really unique in this. And maybe she can even talk in real time how we're working on this. Julia?
Yeah, absolutely. I think one of the important aspects of an MLP is also, is exactly as you mentioned, is how it can affect the next generation of pediatricians, physicians, lawyers as well. So I trained in residency at Yale, and I was fortunate enough to be working alongside Alice from day one and understanding kind of these ideas that so many healthcare needs are so interconnected with legal needs, and then how that also translates into policy. And all of my colleagues have also trained with this mindset as well, where the idea of the physician as an advocate, it's what we do every single day in a patient room, is also what applies when we are working on broader scales, because all of this is applying right back to being able to make sure that our patients can get access to the care that they need. So it's been this infrastructure is already in place as we're thinking about initiatives that are needed and being able to connect with others. And that the fact that we have this medical legal partnership within the pediatric department, it still is applying across specialties. So we have connected with physicians who are also interested in advocacy, and physicians in training also interested in these issues that affect all of their patients as well, across specialties, across the state, and have continued to really collect support from so many different areas. So people who are here today, I know that, from everywhere from the emergency department to the Department of Internal Medicine to pediatrics have all been working on this issue together, and learning about the different ways that we can make our voices heard and how much more powerful it is in a partnership. This is applied to writing op-eds in a partnership. It's applied to being with state legislators together, and really being able to provide the different voices. We have the patient stories, we don't have legal expertise or the initial experience of going to a state capitol, for example, back in the day when that was allowed. So these constant opportunities for connection have made advocacy kind of almost second nature to our job. And I feel very fortunate that this is a really important issue that we're working on now. And so we're having ongoing meetings with legislators, we're having ongoing meetings with people who are in leadership positions from various organizations who are providing their support for this initiative as well. And thinking about that from the research side, from the policy side, from the clinician side, really all comes together.
And Julia, can you tell us, the people on the call, what is there a bill number or a bill name or a committee that they can focus on and maybe make a contact themselves with their legislator?
I saw Jay was unmuting too. I know that I'm not sure if I've seen the bill number yet for this year. It's coming through the Human Services Committee. Thank you. This is where I still rely on a lot of help and expertise. So contacting your legislator from your local area can be a huge help. So talking about how this was a bill that existed 2 years ago for expanding Medicaid to children. At that time, it was Senate Bill 1057, maybe 1053. 1053, thank you. So it's something that you can reference in terms of kind of the bill that was voted out of committee at that point in time. And if you are interested as well, we have a lot of data and materials too. So you're always welcome to reach out to me and I can kind of set you up with some of the background data, the background information that we have, things related to cost, access, our one pager, all those types of things. I'll put my email in the chat.
Yeah.
Thank you, Julia.
We don't have a bill yet. That's just the simple answer to the question. We're kind of waiting for it to come out. The idea here is that, obviously it does take a village for especially an endeavor like this. It's not only advocates and physicians, it's stakeholders, and then obviously the legislative leadership. But I think the value of what Julia was saying is so critically important. It's the need to kind of look at this in a holistic way when you talk to, because the legislators are so used to hearing from us as advocates, but they really, I think, benefit so much from the individual stories from our partners, and then what it means to, basically be in a clinical setting and dealing with, the extraordinarily difficult dynamic of individuals who are fearful of coming in for care, what the long-term cost of that is, et cetera. So, that is how the partnership lends itself. And the other thing that this entire state partnership can benefit from is this is just a little plug. We'll be sending out an email to all participants after with an evaluation, but an invitation to join the listserv, which will enable us to share, information in a real-time basis, so that we can say, for example, there is a bill, there is an opportunity to do that advocacy that Julia was talking about, and that will enable us, and I think push us as a group, because again, the whole is greater than the sum of its parts here.
Thank you so much, Jay. And I wanted to get in one comment, if she's available. Jessie Hahn is here from the National Immigration Law Center, I think, to kind of echo some of the things and why this is important at a national level. Jessie, can you talk for 1 minute?
Yeah, can you hear me?
Yes.
Thank you. I'm so glad you guys are doing this conference and that the students are working on this issue, because it is just a really, really difficult situation with undocumented frontline essential workers right now and their access to the vaccines. We've seen a lot of pushback from governors in Republican states, just kind of not being particularly sensitive to, like the governor in Nebraska made this comment that, well, we don't have undocumented people working in our meatpacking plants, so that shouldn't be an issue, right? When everyone knows that there's a really high concentration of undocumented people on those work sites. So, so James and I have connected, and we're looking forward to talking with the students more about the work that they've been doing. But I do think that, the entire pandemic has kind of forced people to, I think, in the advocacy world, really be responsive to what's happening on the ground and get outside of silos that people have kind of traditionally been in. And so in our world, that has meant, that even though I historically have been a worker rights advocate, I've been working on submitting comments around vaccine access, because that's what workers need right now. And so it's great that you guys are doing this. And I forwarded James some information about a hearing that's going to be happening on the Hill in a couple of weeks about vaccine access. We think it would be great if you guys maybe took your paper and turned it into a comment for the record for that Hill hearing. But I think in general, it's just really important to be raising up the issue, because we know that employers are pushing for vaccine access for their people. I think, frankly, there's a question about whether or not they're doing that kind of in their own self-interest, because then they don't have to pay for things like distancing, PPE, and other things like that. But at the end of the day, vaccine access is really important. It is going to save a lot of people's lives, and we know that the impacts have been just incredibly disproportionate in this pandemic on low-income communities and communities of color, and undocumented workers especially. So it's great to connect with you guys, and congratulations on all your work, and look forward to talking to you more.
Thanks so much.
Thank you, Jessie. That's kind of a wonderful capstone comment. I think that this really reflects how MLP not only benefits from being an interdisciplinary model, but being a model that extends all the way from the front line, from the ground floor, all the way to the top, because the people in DC need to hear the perspectives from people who are engaging with you every day. And this is kind of a mechanism for doing that. So thank you to all the presenters on that closing plenary. It is 12:30, so I want to turn it back to Jay for any other closing comment.
Thanks, James. Thanks for taking us through that. And punctuality, as my dad used to say, is next to godliness. I don't know why, but he was a pretty punctual guy. So well done. So thank you, everybody. First, I just want to reiterate my thanks to our team, all of my colleagues at CCA, and again, a big thank you to Kiana. She was totally invaluable here, and thank you for all your hard work. Christy, James, Cindy, Darren, all the presenters, Linda, all of you folks, Bonnie Roswig, of course, who presented. Thank you so much for conducting those breakouts. Our partners, Yale New Haven, Connecticut Children's, CHC, Fairhaven, et cetera, the Yale Child Study Center, very much partners in this and helping us put this together. We appreciate your attendance. Hopefully next year, if all is well, we can do this in person in in a big conference area and maybe really get to know each other a little bit more. But in the interim, as I said, we'll have an invitation to a listserv so we can at least communicate through that way, and we'll do the best we can. But to keep everybody informed in real time, we're also going to send out an evaluation, which is really important. And the idea of a recording, we'll have to see how it comes out, and we'll try to get it online, and we'll have access to that for anybody who didn't attend. Finally, just a real closing thought. An old mentor of mine used to say, what did you learn and where do you go from here, right? What did you learn and where do you go from here? Today, I think we were really lucky to carve out an entire morning. We have a big road ahead of us as healthcare providers, as legal advocates, as social workers, as clinicians, and everyone encompassing this world of MLPs. We have a big a job ahead of us, but the road enables us to shoot high, right? Emerson said, we aim above the mark so we can hit the mark, right? So I think our job here is to aim above the mark. If we come close to hitting the mark, we can do, I think, wonderful things in the idea of partnership to further the road of health equity, health justice, and trying to kind of create a better system, and certainly on a day-to-day basis, create better outcomes for the individuals that we work with and that we partner with. So a really rich thank you to all of you for devoting an entire morning to this. I'm going to stay on for a few more minutes if anybody wants to schmooze or chat.